for the test. Just in time, Trey. Just in time. All right, so we'll run through the PANTS blueprint and some other things that I think will be useful for you. So let's start with conjunctivitis. Okay, we talked about 3 main types of conjunctivitis. Right, we kind of just showed you them when we went through the red eye differential slide. So you got bacterial conjunctivitis, viral conjunctivitis, and allergic conjunctivitis. In each of those 3, you should be able to differentiate based on either the type of discharge or the patient's symptoms. Okay? So what do you remember about bacterial conjunctivitis?
Purulent discharge.
Mucopurulent discharge. Yeah, very good. And how do you treat bacterial conjunctivitis? What type of antibiotic? I don't care that you know the exact type. What I want you guys to know is it oral or topical? Topical, yes. So topical antibiotic for bacterial conjunctivitis. Why? Because you're putting the antibiotic right on top of the infected part of the body. Okay, very good. Then we had viral conjunctivitis. What type of discharge? Watery, serous discharge, yep. How is that going to present? One eye or both eyes? One eye, and then, yeah, are they going to get it in the other eye? Probably, yeah, almost assuredly. Okay. And how do we treat viral conjunctivitis? Yeah, you basically don't. The body's going to get rid of it on its own, self-limiting condition. We don't prescribe any antivirals for viral conjunctivitis. But you do want to counsel the patient that it is super contagious and they need to wash their hands a lot. And don't touch their face. Okay? And then we had allergic conjunctivitis. What do we remember about allergic conjunctivitis?
It's also itching.
Itching. Yeah, itching. How do we treat allergic conjunctivitis? Yeah, topical or oral? Could do oral. Topical antihistamines work really well for allergic conjunctivitis as well. Okay, very good. All right, moving on. What is a cataract? Not a hardening. Cloudiness. Cloudiness of the crystalline lens. Yeah. So what type of symptoms might patients with cataracts be feeling?
Blurred vision.
Not feeling, yeah, seeing. Blurred vision, yeah, potentially. What else? What about like if they're driving at night? Glare. Glare, yeah, haloing, distorted vision, absolutely. And how do you treat a cataract?
Surgery.
Surgery. What does the vision have to be for a cataract surgery? 20/40 or worse. Yeah. Very good. What if they can read 20/40 on the chart, but they're complaining of glare at night? Yeah, you can do the glare test. And then they'll probably be worse than 20/40 if you do the glare test. Very good. Okay. I don't know if this got mentioned, but I would say 50-ish% of the time, patients will, for whatever reason, confuse a cataract and glaucoma. I don't understand why, but they will say either I've got glaucoma, I had the surgery, and now I can see again, and it was awesome. Like, okay. Maybe, do you mean a cataract? Like, oh yeah. Or they'll say, yeah, I've got a cataract, and it's okay, I'm managing it, I take the drops every night before I go to bed. And they're probably referring to glaucoma. I don't understand why, but patients will oftentimes confuse that. Or they'll have a cataract, and then they'll ask you for a marijuana prescription. not effective for cavities. Okay, moving on. Corneal ulcers, we already kind of talked about this as well. A corneal ulcer is going to present how?
White dot.
Focal white opacity on the cornea. Yeah, it's a white dot on the cornea. And then a special note about that focal white opacity, it's going to have overlying epithelial damage. So when you put sodium fluorescein on to a corneal ulcer, that ulcer will glow when you're using the cobalt blue filter. Are they painful?
Yeah.
You better believe they are. And how do patients oftentimes get corneal ulcers? Contact lens wear is pretty high on that scale. Okay. Corneal infections, we talked about these as well. You can have bacterial infections, viral infections, fungal infections. How do you treat corneal infections? How do you treat a corneal bacterial infection? Antibiotics, okay? Drops. It's on top, yeah. Depending on the severity of the infection, perhaps they may need oral or systemic antibiotics, but typically we'll use topical antibiotics for corneal infections as well. What about viral infections? You could use topical antivirals. You could use oral antivirals as well. I think I said I typically just use orals for corneal infections, viral infections, because the topical ones are a little caustic. And then fungal infections, we'll try to use an antifungal, topical antifungal. Hopefully they don't get a fungal infection. Those are harder to treat. Okay, we talked about keratitis. Specifically, we talked about a viral type of keratitis. Anybody remember what that was? What virus? Herpes. Herpes simplex keratitis we talked about. What is unique about herpes simplex keratitis? Not abrasion, it's that dendritic lesion. Yeah, classic dendrite, that is herpes. How do we treat that? Antivirals. Yep. And then we talked about a pterygium. Okay? What is a pterygium? Pterygium does. Yeah, pterygium goes onto the cornea. It's that wing-like fibrovascular tissue that grows onto the cornea. It extends onto the cornea. A pterygium, like a pterodactyl, has a wing. That wing goes onto the cornea. Pterygium also looks like a harder word to pronounce than pinguecula. It's worse. It's a worse word. And if it's grown onto your cornea, that's a worse thing. It's going to affect your vision. I'm giving you all the tidbits that I use to remember these conditions. Okay, so if it's not on the cornea and it just stays on the conch, it's pinguecula. Okay. One of my last optometry tech classes, they said they just remember like a penguin. Penguins are nice. It's nicer if it stays on your conch. Penguin. Okay. And then we have a corneal abrasion. We talked about that as well. What kind of signs or symptoms is that patient going to be having? Pain. Lots of pain. Yeah. So let's say you are doing land nav. Okay. Didn't wear your eye pro. Scratch your eye. You're going to be in pain. We're concerned about an infection. Okay. What type of infection would we be concerned about? So how do you treat it? You always start with an antibiotic. Yep. Always start with an antibiotic. Don't forget that. And then it'll not work, and it'll get worse, and then you put them on an antifungal. But first, you're going to pump. All right. And then now we move on to some inflammatory disorders. Okay. What is iritis? break down the word iritis. What does that mean?
Inflammation of the iris.
Inflammation of the iris. Yeah, very good. So an iritis is an inflammation of the iris. Okay. We have uveitis on here too. Is iritis a form of uveitis? Yes, it is. These words are really weirdly written, and if I were making a pants blueprint, I would probably just have uveitis on there, and then iritis is a subset of uveitis. But remember, uveitis is an inflammation of the uveal tract. So the uveal tract consists of any of the vascularized tissues inside of the eye. So we've got the iris, we've got the ciliary body, and the choroid. Those three items can become inflamed, and if they're inflamed, then we call it uveitis as sort of a blanket term. So if I have a patient coming into my clinic with an iritis, I'm probably just going to call it uveitis because I don't know if it's iritis. I can't really see behind the iris to the core, to the ciliary body, so I don't know if the ciliary body is also inflamed. So uveitis is typically a blanket term for inflammation inside of the eye. It's called anterior uveitis if it's in the front, posterior uveitis if it's in the back. So if a patient comes in with an iritis or other type of uveitis, what signs might you see in that patient's eye?
Pain during dilation.
Injection? Yeah, what type of injection? There was a specific type of injection that we talked about. It was the injection right around the limbus. Circumlimbal injection, we also call that ciliary flush. Okay, so it's red right around the limbus, circumlimbal injection. That is a sign of uveitis. What other signs do we talk about?
Pain.
What's floating around in the anterior chamber? Like aqueous, typically, in a healthy eye, it's going to be aqueous. In an unhealthy eye, or an eye with uveitis, there's other things that are floating around in the anterior chamber. White blood cells, what do we call that? Aqueous cell. So you might have cells floating around, white blood cells. And you can also have aqueous flare. That would be the protein particles that float around in the eye. So cells and flare, circumlimbal injection, those are indicative of uveitis. Those are signs of uveitis. Symptoms, patients are going to be in pain, right? Remember, they're going to be light sensitive too. Okay, that's the whole sore muscle moving. So what are we going to do to treat these patients? We dilate them, yep, very good. And then what else?
Steroids.
Yeah, what kind of steroid? Correct. Topical steroids is what we, meaning myself and ophthalmology, would prescribe. You guys would punt to us, okay? So topical steroids for the treatment of anterior uveitis. Very good. Then we talked about scleritis and episcleritis. Okay? What do we remember about scleritis and episcleritis? Episcleritis does blanch when you put what on? Phenylephrine, 2.5%. Phenyl, 2.5%. The vessels will blanch. So the red spot of the episcleritis will become white after you put in phenylephrine, 2.5%. Okay? What about pain for episcleritis? Are they in pain? A little bit. Okay, a little pain. It can be like anywhere from a 1 to maybe a 3. So mild pain with episcleritis. They'll know typically that something's wrong with their eye. And then you'll see a focal area of redness. You'll put your phenylephrine on, and you'll be like, okay, you just have episcleritis. So what are you going to do then to treat that patient? How do we treat episcleritis? You could use an NSAID, yep. or artificial tears. That works just fine. If it's worse, and they're in quite a bit of pain, just punt, because we'll give them topical steroids. Okay. And let's say now that the vessels don't blanch. Now we're concerned about what? Scleritis. What signs might you see as a provider with a patient with scleritis? Bluish hue to the sclera, yep, very good. What'd you say? More pain, yep. Yeah, they'd be in more pain. How do we classify or quantify that pain?
Boring.
On test questions, yep. Deep boring pain. Deep boring pain. Bluish hue to the sclera. And what are we going to do to treat that patient? Definitely punt that, yeah. Ophthalmology. They'll probably be getting systemic steroids. Treat that. I too will punt that to ophthalmology. I ain't got time for that. Okay, moving on now to lacrimal disorders. Lacrimal disorders. There are 4 of them. Dacryoadenitis. What is dacryoadenitis? What does dacryo mean?
Nope.
What disorders are we talking about? The lacrimal disorders. So dacryo means lacrimal, very good.
Inflammation of the lacrimal duct.
Lacrimal gland, very good. Why is it lacrimal gland and not lacrimal sac?
Because it's adeno.
It's gland, yeah. Good. So let's jump right then to dacryocystitis. What is that? Inflammation of the lacrimal sac. Very good. How do we treat dacryoadenitis or dacryocystitis? Yeah, that's a good one. What class of drug is that? Very good. And oral or topical? Oral, yeah. Why don't we give topical medications now? Yeah, it's inside. The infection's inside. Topical is not going to touch it at all. So oral antibiotics for dacryoadenitis, dacryocystitis. Dacryocystitis is going to have the other place that you might see mucopurulent discharge. Okay, so the lacrimal sac is nasally, right? And so there'll probably be a bump on that lacrimal sac or nasally, and maybe some mucopurulent discharge coming out of that too. And some pain. Okay. And then we had dacryostenosis. What do you remember about that? Not a damn thing, huh? The nasolacrimal duct is obstructed. What type of patients get this a lot of times? Kids, infants, typically under the age of 1. Okay. So you got a frantic mom bringing her child in. This kid keeps crying. Okay. What are you going to tell that mom? Quit hitting your kid. Just kidding. Why are they crying so much? It's probably a you thing. I don't know that either. What you can do, besides punting, right? Because we have to do some further testing to confirm that it's dacryostenosis. But once we figure that out, what can we tell that mom? How do we treat it? Could massage. Yeah. Typically, like over 90% of these will open up once that kid gets to the age of 1. So that duct will actually just open up spontaneously, which is good. If it doesn't, then they need to get a really aggressive surgery where they're like drilling an opening in there. It's pretty aggressive. We don't want to do that. So hopefully it'll just open up on its own. That's dacryostenosis. Then we had keratoconjunctivitis sicca. What is that a fancy name for? Dry eyes. Okay. Sicca, you just think of as dry eyes. We talked about different ways to treat dry eyes. What's the most basic way to treat dry eyes? Artificial tears. Yeah, very good. Sometimes you can throw some warm compresses on there as well. But artificial tears is going to work for a majority of patients. If you have to do anything other than artificial tears, like scleral lenses or Restasis or a topical cyclosporin drop, hunt to optometry or ophthalmology. We will handle that. Okay. Moving right along, lid disorders. Blepharitis, what is that? Inflammation of the eyelids, very good. How is that patient going to present? What signs are you going to see? Gross. Yep. Gross. Crustiness, scaling, flaking of the lashes. This is where those Demodex mites come in. Those are pretty gross too. How do we treat blepharitis? I love tea tree oil. Yeah. There's lid wipes that you can use that have tea tree oil in them. Just better hygiene often goes a long ways as well. Lid scrubs, scrubbing the lids in the shower, getting that gunk off of there. Okay. All right, bumps on the eyelid. We talked about these already as well. Chalazion and a hordeolum, how do you differentiate those two? Pain or no pain? Yeah, pretty much. Hordeolum hurts, okay? So hordeolum is going to be an acute, painful bump on the eyelid, right? Not necessarily the whole lid swollen, but just kind of a local bump. Okay. How do we treat a hordeolum? You could use warm compresses, yep. The Bruder mask. You could also use a Bruder mask, yeah. Love the Bruder mask. Not a topical for hordeolum. I will oftentimes just put these guys right on an oral antibiotic, Keflex or Upman. If that hordeolum does not go away, what can happen? Could turn into what? It already kind of is a cyst. What could a hordeolum turn into?
Cellulitis.
It could turn into preseptal cellulitis, yeah, which could turn into orbital cellulitis, which again is, that's why I'm aggressive. That's why I'm aggressive with hordeolums and treating them with an oral antibiotic, because I don't want it to turn into preseptal cellulitis. But let's say it doesn't turn into preseptal cellulitis. Let's say the body just sort of controls it, encompasses it, but it doesn't fully go away. What's it potentially going to turn into? Chalazion. Okay, so it's not painful anymore. It's just like a calcified bump on the lid, a painless bump on the lid. Remember, that's a chalazion, chronic condition. Chalazion. How do we treat chalazion? Correct, whoever said warm compress, and also correct. So the DHA makes us make the patient use a warm compress for like 3 weeks or a month or whatever it is, and try to get the chalazion out, and then it's not going to come out. Have you ever seen one come out? I've never, with a warm compress. Yeah, same. Don't. It's one of those dumb DHA things. And there's a lot. But once it doesn't come out with warm compresses, then we're going to refer to ophthalmology. And ophthalmology is either going to incise and use their ice cream scoop to scoop it out, or inject it with steroid. Okay. And then we have ectropion and entropion. Remember, these are the lid malposition conditions. What was ectropion? Outwards. Outward turning of the eyelid. Who gets ectropion? Old people a lot of times, yeah. That skin just becomes lax, falls away from the lid. So if you have ectropion, what else might you have? Not necessarily a ptosis. That, no.
Scratch your eyelid.
Dry eye, whoever said that, yeah, very good. The lid is not going to close fully. What do we call that? When the lid does not fully close.
Lagophthalmos.
Very good, leg ophthalmos. Excellent. How do we treat leg ophthalmos? Yeah, probably. We do the same basic treatment for leg ophthalmos as we do for any dry eye patient, right? Their eye's going to be dry. So we're going to start with artificial tears. That's not going to work. Then we'll punt after that, optometry, ophthalmology. We might use some thicker medications, drops to stay on the eye longer. They might insert gold weights in the upper eyelid to try and get those eyes to close. Maybe a tarsorrhaphy, suturing the eyelids together. Lots of different ways. But remember, when we're doing our treatments, we're going to try to start at the most simple treatment first, and a lot of times that's going to be artificial tears for any dry eye condition. Okay. So ectropion is an outward turning of the lid. Entropion is an inward turning of the lid, right? What symptoms is that patient gonna? Irritation, yep, because you've got a bunch of eyelashes scratching up against your cornea. And how do we treat entropion?
Surgery.
Surgery is basically what you're gonna have to do. They're gonna have to go in and reposition that lid. Ophthalmology is repositioning that lid so it's not scratching against the eye. Okay, nystagmus. What is nystagmus? Yeah, constant beating of the lid, of the eyes. Very good. How do we treat nystagmus? It's a great question. You got to figure out what is causing the nystagmus, first off. If it's some sort of drug that the patient's on, take them off that drug. If they're born with it, not much you can do about it. Patients are going to be visually disabled for their life. It's really hard to look at something when your eyes are constantly zigzagging back and forth. Optic neuritis, what do you guys remember about that?
It's inflammation of the optic nerve.
Inflammation of the optic nerve. Yeah, very good. What's that nerve going to look like? A little pale, yeah. Inflamed, yeah. Potentially maybe a little swollen, okay? But it's just one eye a lot of times. What's that patient going to be feeling like? Pain or no pain? Typically, they're in a little bit of pain, especially when they're moving their eyes around. We call it pain on eye movement. So if they're looking around with their eyes, because that optic nerve is inflamed, and that sort of moves when you're looking around, that's going to cause the patient a little bit of pain. What's their vision going to be like? Not great. It's going to be decreased, right? Because the optic nerve, which sends your visual signal back to your brain, is inflamed. So it's not going to work quite as well. Okay? What systemic condition is optic neuritis often a sign of?
MS.
MS. Very good. Very good. And how are we going to treat optic neuritis? Yeah, probably systemic steroids. Okay, so that's optic neuritis. Typically, that's going to be a unilateral condition. If you have bilateral optic nerve head swelling, what is that called? It's the next one on the pencil blueprint. Papilledema, very good. Bilateral optic nerve swelling, papilledema, edema swelling, papil optic nerve. Okay. Bilateral optic nerve swelling is called papilledema. So patients with papilledema, when you look inside of their eyes, what are you going to see when you're looking at their optic nerves? Both of them are going to be swollen. Has to be both, because papilledema means there's an increase in intracranial pressure. Okay. Remember, the optic nerve head is sort of the furthest forward portion of the brain. So something's swollen inside the brain that's pushing ahead on that optic nerve head. That's why you see the bilateral optic nerve head swelling. How do we treat papilledema?
Steroids.
there's a specific order of things that you need to remember. Do not remember exactly what slide it is, but there's a certain slide in your optic neuritis or papilledema lecture. It tells you what you need to do first. I don't remember off the top of my head. Lumbar puncture was one of them. That's not first. You don't want to do that first. You want to get an MRI first. You got to make sure it's not a tumor that's causing the compression. Yeah, that's a good one. I think that's first. You found the slide? Nice. Read them all, because there's a few on it.
Start with blood pressure,
Yep.
MRI with contrast, then lumbar puncture, and neurosurgery consult and ophthalmology.
Beautiful. Could not have said it better myself. Excellent work. All right. So if you have any sort of issues with your optic nerve and you're testing a patient's pupils, you may have some pupil abnormalities. Specifically when you're doing the swinging flashlight test. What are you testing for with the swinging flashlight test? Sort of.
Pupillary.
Also no.
Pupillary reflex.
Which one?
Pupillary reflex.
Which one? Testing for a type of pupil defect.
Pupillary afferent defect.
Afferent pupillary defect, the APD, very good. Afferent pupillary defect when you're testing with the swinging flashlight test. Who doesn't understand an APD? Very good, yes. This is a tricky concept. If you have a right eye afferent pupillary defect, and you shine a light into that patient's eye, what is going to happen? Shining a light into the right eye with the right APD.
Nothing's gonna happen.
Nothing is going to happen to that pupil. Then you swing the light over to the left eye. What happens?
They both constrict.
Both pupils will constrict. That side's normal.
See, I'm not looking at slides.
When you swing it back over to the right eye with the right APD, what happens?
Dilation.
To which pupil?
To both.
To both pupils, yes. Why is that the case? Because something is wrong with the optic nerve on that right side, so there's no signal getting back to the brain. If there's no signal getting back to the brain, then the brain can't tell the iris to constrict, right? But when we swing the light back to the other side, both pupils will constrict, because that side's normal. Okay. So when you're testing, when you have a patient with an APD, and you're testing their eyes, the damaged side, nothing is going to happen to those pupils. Swing it over to the other side, then both pupils will constrict. Swing it back to the bad side, both pupils will redilate. They're not dilating, they're not getting bigger, not like when you put dilating drops in and it really makes your pupils big. Don't confuse that. They're just going from a small state to a larger state. And anytime you do that with the pupils, we call it dilation. That make sense? Study APDs. All right. Orbital cellulitis and pre-septal or periorbital cellulitis. How do we differentiate those two conditions? 4 things that you need to check out. Pain with eye movements is one, yep. Proptosis, yep, very good. Restricted eye movements as well. And what else? Just talked about. Afferent pupillary APD, or restricted vision. Okay. So if you have those 4 things, or one of those 4 things, and you've got a swollen eyelid, we're much more concerned that the patient has orbital cellulitis. Orbital cellulitis, much worse than preseptal cellulitis. Because orbital cellulitis means that infection now has a free track to the brain, and we don't want that. Okay, so what are we going to do if a patient has pain on eye movements with a swollen eyelid?
Aggressive antibiotics.
Aggressive antibiotics, yeah. Punt them to the ER where they're gonna get started on systemic, probably IV antibiotics. If there's no pain on eye movement, no proptosis, no restriction on eye movements, and vision is normal, they just have a swollen eyelid, then they probably have preseptal cellulitis, in which case we can treat it with what? Oral antibiotics. Yeah, very good. Okay. All right. Let's run through retina and then we'll take a little break. Macular degeneration. What is macular degeneration? How would you describe that?
Degeneration.
Degeneration of the macula. Beautiful. Very good. Nothing better
Using the word
than defining something. Really, that's what it is, though. The macula is not working anymore, okay? And without going too deep into it, you can just think of it like that. The macula is not working anymore, okay? There's a waste product that gets built up in the macula. You guys remember what that was called? It's like a little yellowish deposit in the macula. Started with a D, ended with a drusen. 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 Okay? If you have drusen in your macula, you have macular degeneration. What are some signs that patients might see, or what might they notice? Central, yeah, with like end-stage macular degeneration, perhaps some color vision defects. Early macular degeneration, a lot of times patients will notice that like a door frame isn't straight. A door frame will have a little blip to it. A lot of times, if they get a drusen right over where they're looking at, that drusen will distort the retina, and whatever they're looking at will also be distorted. We give patients a little grid. Do you guys remember what that was called? Amsler grid, the home Amsler grid. And we'll have patients test themselves to see if their macular degeneration is worsening once a week, maybe once a day, however much the patients really want to do it. And all they do is put this little grid on their refrigerator, cover an eye, make sure they can see all four corners, all four sides, and make sure there's no lines that are missing or wavy or blurry. And then do the other eye, same thing. What are some risk factors for developing macular degeneration? Age, yeah.
diabetes. It's always
Smoking.
So if you're smoking, yep, very good. Yep, ripping darts. I looked up a bunch of, when Coach Ryan was talking about macular degeneration, I was in the back, I looked up a bunch of slang for smoking cigarettes. There's a lot. They're fun. How do we treat macular degeneration? It's a great question. What is dry macular degeneration? What is wet? Neovascularization, yeah. Let's say it's dry. What are we going to do to treat that patient? Yeah. Is that going to treat it? No. Maybe. I know that's what it says, and that's what the vitamin people say too. It might. Clearly, I'm not sponsored by anybody. It might, but basically, they're probably going to go blind. So we're going to try to preserve as much vision as we can. Basically, if I have a patient that comes in with macular degeneration and I can smell the cigarettes on them, I'll tell them to stop smoking. It's one of the best ways to do it. Eating some green leafy vegetables, maybe it'll help a little bit, but not much you can do. Now, if they have wet macular degeneration, what are we going to do? You say laser. You could laser, yeah, you could. More commonly, though, what does ophthalmology do? Intravitreal shots, anti-VEGF medications. VEGF, vascular endothelial growth factor. Your body is sending a signal to grow new blood vessels. Those blood vessels suck. They're really leaky, and they leach into the vitreous, and we don't want that. So we'll give shots in the eye. And a lot of these patients with wet macular degeneration will say that they're getting their macular degeneration treated, because they're getting the shots. They're not treating their macular degeneration. They're just minimizing those blood vessels inside of the eye. Because those blood vessels, like I say, can leach into the vitreous, and if you have a violent movement with your eyes, that can actually cause a retinal detachment, which we don't want to happen.
So what are those shots doing again? They're growing new blood
So
vessels or getting rid of blood
They're
vessels?
getting rid of the new blood vessels. Your body will secrete vascular endothelial growth factor when it's starved of blood vessels. If you have an area in your retina that becomes ischemic, your body's going to secrete new blood vessels to it with the vascular endothelial growth factor. What the shots do, it's anti-VEGF. So it combats that growth factor and then stops the new blood vessels from growing. Good question. All right, let's take 10 and then we'll finish up.
Slides? I'm just writing it down. So I'm writing it down as he's saying it. Then like I can write it. Just like put
No. Oh yeah, no.
I just went over my versions that take this requirements. Like 2 months of training.
Oh wait. I love the fact that you think the kid. He did that like that was the very first weeks that I joined you guys. It's always a kid. It's always a kid.
Where's that read? I could have an advanced call and then schedule my Philippines part 2.
Where did you guys put in their
Yes.
I already said what I'm bringing.
Beauty is 155.
Like, he's
7.5. Alexander Blake wrote his policy.
I've heard that's really good. I've never tried it.
think they just exist because you bring them to the
Yeah.
Yeah.
I bought a beer for him after.
He exists. No, when I was telling him about it last night, I was like, oh yeah.
I was gonna separate it by this.
As far as I tried it on my laptop, it didn't work, so I went downstairs to offices and there.
Yes, 786 514
No,
167.
so you go on to Mott's.army.mil.
I did not say that. I was just saying like, hey,
Once you get to that landing page, you have the instructions right there on the landing page. Because it'll say, welcome to the 68 Whiskey System. And then it's got a list of how to submit it. So you'll go through those steps, hit the restart button, through the 68 Whiskey System, and then you can hop on it or just click the certain zone.
What do you have in the afternoon? I can do it at 1 p.m. Yes.
Actually, he was just saying that they do that.
Yes, that's right.
Plantains.
Have it.
Is that what dog fight?
That's it. Looks good, but it's slow.
Telling him it was really
They have like the appointment line like outdoor, so you can go like make sure you have your insurance ready when the doctor calls you. And like she answers like San Antonio, I'm like, you know, she has to eat myself. I'm
He was getting Vietnam flashbacks.
yeah. She said like 4 times. I'm like, okay, I forgot. I'm pretty much I have like dead old hair cut walking
Hey, when it's
Don't.
I didn't know it was like that.
Nope, that's wrong.
I was sidestepping. You got your way.
You don't want to be high.
I got 100 on all three of the classes. Somebody's had to. I'm saying you're like saying you're gonna get a kid on your back kids. Those little questions make sense when you throw a fucking panel at me.
It makes me like, it's like if you don't think of it as a panel, look at it like for your little boys.
Okie dokie. Had a question at the break about different types of antibiotics. When I looked at the test right before I came over here, can't remember offhand if there are any specific topical antibiotics listed as answer choices or orals, like Keflex or Vigamox or whatever. What I want you guys to be familiar with is, does this condition require a topical antibiotic, an oral antibiotic, a topical steroid? How do you treat this? I don't care that you know the exact ones or specify that Vigamox is a topical antibiotic or Keflex is an oral antibiotic. You'll learn all of that in due time. I just want you to know the basics. This is a hordeolum. I'm going to treat it with an oral antibiotic. This is bacterial keratitis. I'm going to treat this with a topical antibiotic. If you get to the test and there are specific questions about medications, just raise your hand, say, this says Vigamox. What is that? And I will say, that's a topical antibiotic. Okay. I'm not going to tell you that that's the right answer, but I'll tell you, I will classify medications for you on the test. No right answers. Huh?
Thank you.
Yeah, that's my guess. All right, so we left off with macular degeneration, talking about the two types, dry and wet. And then we said that wet macular degeneration has neovascularization associated with it, new blood vessel growth. And that new blood vessel growth can leach its way into the vitreous. And if you have a violent movement of your eye, that can tug your retina off, detach your retina. That is one of three types of retinal detachments that we talked about. What kind specifically was that? Tractional. A tractional retinal detachment. Very good. What were the other two kinds? One started with an R, and it's really hard to pronounce. Rhegmatogenous, very good. Rhegmatogenous retinal detachments happen when there is a tear in the retina, and fluid gets behind that tear, and the retina detaches. And then there's another type of retinal detachment with no neovascularization, no tear. There's fluid that gets underneath the retina. It's exudative retinal detachment. Serous. Yep, very good. Okay. What signs and symptoms is a patient going to have if they have a retinal detachment? Flashes of light. Floaters. What else? Sudden loss of vision. Yeah. What might that patient describe it as? A curtain following your vision. Yep, very good. Like a graying out or staticky vision. Those are hallmarks of a retinal detachment. So if you have a patient that calls in with one of those, what do you do? Exactly. Where do you punt to?
Ophthalmology.
Yeah, ophthalmology. Or an ER who has an ophthalmologist on call. Yep, very good. Let's say the patient calls in with complaint of new flashes of light and new floaters. And you ask about a curtain falling over their vision or any other visual issues, and they say no, just flashes of light and a floater. What do they have then? Posterior vitreous detachment, PVD. Remember PVDs? So vitreous detachment is not a retinal detachment. It can lead to a retinal detachment, but But a vitreous detachment is not. Remember, the vitreous is that jelly inside of the eye that sits up against the retina. And as you age, it liquefies and sort of shrinks away, and it'll pull itself away from the retina. And again, anytime you have tugging or pulling on the retina, there's going to be flashes of light associated with that. And sometimes there's new floaters that appear, specifically that Weiss ring, where the vitreous is attached to the optic nerve. It'll pull away at the end, and it'll leave a ring floating around in this patient's vision. Right smack dab in the middle, the patients are going to be freaking out because there's a huge floater that wasn't there yesterday and it's there today. It's going to be very noticeable. As long as they still have their peripheral vision intact, it's not a retinal detachment. It's just a vitreous detachment. Much less concerning. We still want those patients to come in though. So you're going to tell them they need to come in to an optometry or an ophthalmology clinic to get a full dilated eye exam. Because we want to make sure that vitreous did not tear the retina. If it did tear the retina and then fluid gets behind that, you can have a rhegmatogenous retinal detachment. Flashes and floaters with no loss of vision, PVD. Flashes, floaters, loss of vision, retinal detachment. Okay, we talked about a few different types of retinopathy. Talked about diabetes, diabetic retinopathy, and there were two types of diabetic retinopathy, just like there's two types of macular degeneration. You guys remember the two types? It's not dry and wet, that's macular degeneration. It's similar though. You could think of the dry as the non-proliferative diabetic retinopathy, and the wet with the neovascularization is proliferative diabetic retinopathy. So there's something proliferating in the retina. That'll be the neovascularization. That's your PDR, where you're going to get intravitreal shots for the diabetic retinopathy to slow the blood vessel growth down. And then the NPDR, there's no neovascularization, just signs of diabetic retinopathy, which are what? Think of the beets.
Sugar.
Yeah, it's all about the sugar. Okay, so if you've got diabetic retinopathy, you've got a bunch of sugar flowing through your blood vessels. That sugar acts like sandpaper. It wears away the inner lining, and those blood vessels are going to leak. So you're going to have bleeding, remember? Dot, blot hemorrhages in the retina. Maybe some exudated material in the retina. Retina's not going to look normal. Mostly it's bleeding. Okay? And that's how diabetes works throughout the rest of your body. You lose a foot because you've got a bunch of internal bleeding. That's why you see an eye doctor every year if you have diabetes. We're looking at your retina, seeing if there's any bleeding in your retina. If there's not, then you're probably good throughout the rest of your body. But if there is, then you're probably screwed. And you need to get your sugars down. Spoiler alert, that's how you treat diabetic retinopathy. We don't do anything unless you have neovascularization. The patient has to get their blood sugar down. So I'm going to punt them over to you. You're welcome. I had a patient with an A1C of 13, barely make it into the office. I thought they were going to pass out. That eyeball was not happy. There was a lot of blood in that retina. Probably a lot of blood throughout the rest of their body. Just slowly bleeding internally. Sure couldn't lay off the stickers. Say la vie. There's a ton of diabetes here in San Antonio. I have a lot of job security. There's also a lot of hypertension here. We talked about hypertensive retinopathy. What signs might you see with hypertensive retinopathy?
Hemorrhages.
Also, some hemorrhages, yeah. It wasn't dot blot for hypertensive. It was more of the flame-shaped hemorrhages with hypertensive retinopathy. What about the AV ratio?
1 to 3. So 1 to
Changes, potentially. From like a 1 to 3 to maybe a 1 to 4. AV nicking. Crossing changes. Copper wiring, silver wiring. Those are all those hallmark signs of hypertensive retinopathy. And then severe hypertensive retinopathy can have that interesting exudative pattern around the macula. Macular star. See that macular star? That patient probably has a hypertensive crisis. What systemic signs are you going to see with a patient with hypertensive retinopathy? Please don't overthink this.
Hypertension.
Yes, they're going to have hypertension. They're going to have an elevated blood pressure. How do we treat hypertensive retinopathy?
Blood pressure meds.
Yeah. Keep the blood pressure under control, and then your eye will stop bleeding. Good. All right. Trauma. We've got a blowout fracture as the first thing here. You just get a blowout fracture randomly?
Osteoporosis.
Some trauma is going to have occurred. So the patients are probably going to be aware of some sort of trauma. Okay? The most common patient population for a blowout fracture happens to be a young 20s male who went out to the bar and ran his mouth. If you have a blowout fracture, ocularly, what do you need to check? What do you need to check for? Vision, yeah. EOMs? Yeah. What are we looking for when we do an EOM check? Yeah, specifically
And look up.
in vision. Potato. Where might their gaze be restricted? Up gaze, yeah. Because the floor is really weak, okay? And if that floor breaks, that inferior rectus can become trapped, which does not allow the patient to look up. So one eye will look up, one eye will look straight ahead. And that eye will be super black and blue. That is a floor fracture. How do we treat those? Punt. I ain't doing it. Ophthalmology. That's good form. All confidence. Okay, next. Corneal abrasion. We talked about this already, right? Scratch to the eye. How do we treat corneal abrasions?
Punt.
Well, yeah, probably. That's a good call. It depends, yeah. If it's small, artificial tears, if it's really big, we'll put a topical antibiotic on just as like a cover to prevent any sort of bacterial infection. Yeah, oftentimes it's just artificial tears if it's a small one, and it'll get better. Patient's going to be in copious amounts of pain. Very painful. Globe rupture. Tell me about a globe rupture. What does that mean to you? Something went in the eye. Yeah, something wasn't supposed to go in the eye, but it went in the eye. Very good. What are some signs of a globe rupture?
Something sticking out of their eye.
Yes, if something is sticking out of the eye, that is a globe rupture. Should you take that thing out?
No.
No, you should not. Okay. What should you do instead?
Punt.
Yes.
Very far.
You can try to limit the eye movement. You're probably not going to be able to do that. You're going to want to put a Fox shield, a rigid eye shield over that eye if you can. If there's something still sticking out of it, what can you put over it instead? A donut? Maybe. If you have a donut available. Krispy Kreme works really good. Yeah, a cup. Cup. Like any sort of cup. Red Solo is my favorite. Does that Red Solo cup protect the eye at all?
No.
No, it does not. What does that do? Why do we put that on there?
Nothing else gets in.
Not even really that at all.
Nothing else gets in.
It keeps people, it's like a tractor beam or a warning signal. Something is wrong with this eye, please don't touch it. Okay, be very careful around this eye. It's got a Red Solo cup taped to it. Yeah. It's not providing any sort of protection. Just trying to draw attention to that. Let's say you have nothing sticking out of the eye. Something just went into the eye, maybe like a small piece of metal. What might you notice then? Yeah, a peaked pupil. Peaked pupil. Where does that peak point to?
Where it enters.
Where it entered. Yeah. What is what's happening there? The iris is plugging that wound out. Yep, exactly. So the iris is being pulled to plug that hole. When it gets pulled like that, it will form that peak. Okay, very good. What don't you want to order if you have have a patient with a suspected ruptured globe. What imaging? Yeah, don't order an MRI with that. That's metal. That's not going to be a good day for that patient. CT scans are not in there. Hyphema, what is that? Blood in the anterior chamber. How do you get hyphema? Trauma, yeah. Could be ciliary, it could be iris. It's whatever, something vascular inside of the eye is bleeding, and that blood is going to pool inferiorly, okay, because gravity is awesome. What do you do to treat a hyphema? Punt, I will say, you're right on punting most of these. Punt is not an answer choice on the test.
Would have been good if it was.
I think it actually might be for a couple, but a majority of these things I do want you to know at least like baseline treatment for some of these things. But punting is probably the right answer a lot of times. A lot of stuff.
Right. How far?
So we grade hyphemas based on how much blood is in the eye. Okay, one of your slides talked about an 8-ball hyphema. An 8-ball is black in the game of pool, right? So you're going to see just a black eye. The colored part of the eye is going to be completely black. That means the eye is completely filled with blood. That hyphema is going to need much more emergent care than just a smaller hyphema, because that anterior chamber is supposed to be filled with aqueous. When it's filled with blood, it's still got aqueous being produced, and you may skyrocket the pressure inside of that eye. We need to monitor those patients so they don't get traumatic glaucoma. Otherwise, hyphema, basically like any other bruise or bleed in the body, will dissipate with time. So we just have the patients on bed rest typically, and their heads sort of elevated. That keeps the blood in one spot in the eye, so the rest of the anterior chamber can drain that blood out, or drain the aqueous as it's supposed to. Talk about orbital compartment syndrome. What was that? Orbital compartment syndrome. You do, correct. You will do lateral canthotomy cantholysis, where OCS is also an ocular emergency. And orbital compartment syndrome occurs after trauma. Patient's going to have an increase in intraorbital pressure. So remember, the orbit is a bunch of bones. Those bones aren't flexible, and you're going to have pressure increasing inside of there, a lot of times due to a bleed behind the eye, and that's going to push the eye sort of forward. So you have swelling around the lids, and the eye is going to be proptosed a little bit, and we need to reduce that swelling as quickly as possible, because if you don't, it's going to choke that optic nerve off, and that patient's going to go blind. So it's always after trauma. OCS happens only after trauma. You won't just get compartment syndrome sitting here, at least not orbital compartment syndrome. So you have to do the lateral canthotomy cantholysis. So you cut the lateral canthus here, that's going to relieve some of the pressure, and then you're going to cut one of those tendons, the canthal tendons, and it's going to swing forward and allow that blood to leave the eye with the veins that are already in there. Okay? Venous return. Lateral canthotomy cantholysis. When in doubt, if you suspect a patient has orbital compartment syndrome, do an LCC. Because while it may look really gruesome and gross, you could potentially save that patient's vision. And even if they don't have orbital compartment syndrome, it's a really simple surgery to fix up with the oculoplastic stops. Every oculoplastic surgeon that I've ever spoken with has said, please do an LCC so I can fix it, because it's way easy to fix. They don't care. They don't care how bad you are at it. They don't care what it looks like. They will fix it and make the patients look probably better than what they looked like prior to the surgery. They are awesome. Lid lacerations. It's pretty self-explanatory. That is a laceration of the eyelid. If you get a cut in the eyelid, how do you treat it? just gonna suture. Should you suture an eyelid? You as a PA?
No. Depends on where you're at.
Probably not, okay? And I'm trying to walk a fine line between test and real life. Test, maybe. Real life, if you're the only person in 200 miles, just patch them up as best you can. Worst case scenario is, again, oculoplastics is going to go back in and cut a new laceration and just patch it up the way they want to. If ophthalmology is readily available, then punt to ophthalmology. That's what I'm going to do too. There is something in your book or in your slides that says if it's medial, like potentially involving the lacrimal drainage system, don't touch that at all. Send that right to ophthalmology. But if it's like a superior lid cut out here or maybe down here, something temporal, you can probably handle that. But oftentimes, punting to ophthalmology is going to be exactly what you want. We've got the vascular disorders. Talked about 4 main ones, the 2 artery occlusions and the 2 vein occlusions. So the central retinal artery occlusion, what was that hallmark term that you need to remember? Central retinal artery occlusion. Cherry red spot, yeah. So there's no blood getting into the retina. The central retinal artery is blocked. Okay. And you're going to see a very white retina, pale retina, except for the area around the macula. You're still going to see redness there, and that is from the choroid right underneath it. So we call that the cherry red spot. What is a patient's vision with a central retinal artery occlusion? Terrible. Yeah, it's potentially like light perception, bad, very bad vision, and it's sudden. Okay, when that artery occludes, that vision is basically gone suddenly. Okay, and it's noticeable. Will the patient be in any pain? No. Now the central retinal artery occlusion. It's sudden, painless loss of vision. Okay. How do we treat a CRAO? It's really hard. There's a lot of printing that goes on. That whatever's blocking will suddenly stop blocking it. Otherwise, we're going to be given vasodilators, maybe some blood thinners, anti-thrombotics, something to try to block that occlusion. So if you don't get that within an hour, that patient is visually gone, basically, in that eye. So we want to prevent that. Okay. So that would be a central retinal artery occlusion. Central retinal vein occlusion, what do we remember about that? Blood and thunder fungus, yeah. So now blood can get in the eye, but it can't get out. And if it can't get out, those blood vessels are going to pop inside of the eye, and you're going to have a bunch of bleeding, a bunch of exudated material around the eye. Also painless, okay? Sudden painless loss of vision can be a CRVO as well. A little bit better of a visual prognosis, but still pretty terrible. So we want to try to not get a CRAO or a CRVO. Life is easier that way. And how do we treat a CRVO? Kind of the same. Trying to clear whatever blockage is in there. Hope for the best. Not a great outcome though. And then we have the 2 branches. Okay, so it's not the central retinal vein or central retinal artery. It's just a branch of it. So what sort of visual symptoms is a patient going to see if they have a BRAO or a BRVO? Are they going to have total loss of vision?
No.
Yeah. No is the correct answer. It's probably going to be more of like a hemispheric defect. So maybe they lose the bottom half of their vision or the top half of their vision, depending on where the occlusion is in the eye. But then the same kind of things respectively for the artery and vein. So if it's a branch retinal artery occlusion, there's not going to be bleeding going on because there's no blood getting into that area. Instead, you're going to have sort of a pale retina in the area where the occlusion is. And then a BRVO, you'll have a bunch of bleeding, but it's just going to be kind of in that hemisphere, either inferior or superior branch. We talked about amaurosis fugax. What is that?
Can you repeat that again?
What is amaurosis fugax? Fugax, however you want to pronounce it. How do you pronounce it? Fugax? 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 Man, it's a lot. You're probably right. I mispronounced my NCO's name for 5 years. Did I tell you guys that? God, it takes me out. No, I've known my NCO for 5 years. I have called him the wrong name. His name is Sergeant Chabra. I've called him Chabra. Slight variation, but it's still wrong. This guy continued to let me call him Chabra for 5 years. Everybody that he knows in the military, he knows because of me, because I introduced him to everybody. So I have introduced him incorrectly to everybody. He's like, oh, sir, it's not that big of a deal. Like, it is, because I look like an idiot, because I don't know your name. Guy? Oh, guy. Anyway, amaurosis fugax, or fugax. Transient vision loss. So these patients are going to come in, and they're going to be the weird ones. Because they're going to come in and they'll be like, my vision went completely away. For 30 seconds, it's back. Everything looks normal, but it definitely was gone for like 30 seconds. You can't dismiss them as a crazy person, like right away. Because they might be, but potentially they have amaurosis fugax, which can be the early signs of a centroretinal artery occlusion. Okay, so the same thing is potentially happening there. The artery is being occluded, they're losing vision for 20 to 30 seconds, and then that blockage is going away. Okay, so if you have patients with amaurosis fugax, got to do all of the blood labs on them to make sure that they don't have high cholesterol or any other vascular conditions, because potentially that could lead to a CRAO, which we again want to prevent. Amblyopia, talked a lot about that. We want to prevent amblyopia as much as possible. Okay, talked about really 3 main ways you can get amblyopia. Do you remember any of them? What is amblyopia? Lazy eye, yes. The inability to see 20/20. Okay, with best corrected. Amblyopia. I can't correct you to 20/20. So you can get amblyopia 3 ways. You can either have an eye turn, as a kid, eye turn, and the brain doesn't want to see 2 images, so it's just going to shut that turned eye off, okay? Unless we get it fixed, which is why we want to get that fixed. Because if you don't have both eyes working, you don't have depth perception. 2 eyes are definitely better than 1. So an eye turn, you can have also something in the way, deprivation amblyopia, like a congenital cataract, maybe a corneal scar. Maybe something is depriving the light from getting to the retina. You need to get that surgically fixed as well. That's why congenital cataracts are really bad. Corneal scars are really bad. And then you can also have what's called refractive amblyopia. This would be when one eye has a much greater prescription than the other eye does. Okay? The brain is not going to want to focus on the bad eye, so it's going to send all the neural signal to the good eye and basically shut the bad eye off. These patients also need to get eye exams so we can get them some glasses, so hopefully that both eyes work properly. That's refractive amblyopia. Large difference between the prescriptions. All right, we got glaucoma. Talked a lot about glaucoma. I want you to focus on 2 main types. Primary open-angle glaucoma. That's probably the most common type. That's the one that you get typically in your elder years, and you're going to be putting drops in your eyes to lower the pressure inside of the eye. Typically, the pressure inside of the eye is elevated, and that causes damage, irreversible damage to the optic nerve head. And by definition, glaucoma is progressive damage to the optic nerve head with visual field loss. And then you can have acute angle closure glaucoma. This would be when the angle in your anterior chamber just closes off and your pressure skyrockets immediately. So this is something that needs to be treated right away. POAG, primary open angle glaucoma, is painless. Acute angle closure glaucoma is painful. Patients are going to be nauseated, potentially light sensitive. Their pupil's going to be fixed and dilated. Remember in the slides, there's that picture of the older person. It's got like a cloudy cornea on the one side. That pupil's dilated behind it. That eye is going to be rock hard. Pressure is going to be in the 50s or 60s when normal is typically under 21. We need to treat that patient right away. So you've got an angle closure kit somewhere in your medical center, and you're going to put the glaucoma drops on, trying to lower that pressure right away. Once that pressure is lowered, we're going to punt to ophthalmology, and that patient's going to get the laser peripheral iridotomies, the LPIs. Okay, strabismus we talked about a lot. You can have many different types, but a strabismus is an eye turn. So your eye can be turned in, out, up, down, twisted. Lots of different strabismuses, strabismi. How do we treat strabismus? Surgery, typically, yeah. Strabismus doc is going to go in and realign those muscles. We talked about tropias and phorias, and again tomorrow I can go over that a little bit more when you're in your smaller groups. A strabismus is not a phoria though. Strabismus is going to be a tropia. And we classify it based on where the funky eye is positioned. So if it's out, it's an exotropia. It's in an esotropia. Up, hypertropia, down, hypotropia. Okay? Tropia is strabismus. We talked about presbyopia. What is that? You said it before. Huh? Yeah? What did you tell me for cataract? Hardening of the lens. Yeah. So when that crystalline lens gets hard, it can't focus on things up close. When you can't focus on things up close, that is called presbyopia. It's your mid-40s patient. It's my least favorite. We also have myopia. What is that? Nearsightedness. Yep, very good. The eyeball is typically too long, and the light rays come to a focus in front of the retina. And then you've got hyperopia, which is farsightedness. You can see things far away, you can't see things up close quite as well. And then there's astigmatism, which is really hard to explain. There's multiple sets of light rays entering the eye. The cornea is not spherical, it's more like a football instead of a basketball. Let's see. We talked about giant cell arteritis, everybody's favorite, GCA. What signs and symptoms is the patient going to have with GCA? Yep. Jaw claudication, hallmark term. Loss of vision, absolutely. Typically this is like your male 60-year-old, 70-year-old patient. Okay. How do we treat GCA? What labs do you order for GCA? What labs? Yep, BSR-CRP, very good. And then how do you treat it? Steroids, great. Maybe a temporal artery biopsy to confirm. Yeah, ESR and CRP are going to be elevated. Temporal artery biopsy confirms. Talked about some neoplasms, benign ones. Two main types we talked about, well I guess three. We talked about basal cell carcinoma, squamous cell carcinoma, and a malignant melanoma. Basal cell is malignant, most common form of skin cancer, okay? Pearly nodule with telangiectasia, okay? And then squamous cell kind of looks like a scab that won't heal. So if you see a patient that's got something funky going on with their skin, ask them, how long have you had that? And hopefully they haven't had it very long. Or they have, and it's benign. Some people will have malignancies that they've had for a long time, and then they'll get pictures taken of them and there'll be case histories. So, ask patients questions. We talked a little bit about benign neoplasms, not a whole lot. Trying to think of any off the top of my head. We did talk about. I don't think any. I'll add some of those slides later. You guys don't have to worry about that. We did talk about triage though. There were some triage slides that would be good to review. Triage is important. It's important that you guys know what these diseases are, but it's also important that you know which ones are really important to treat. Otherwise, you might be treating a chalazion when you've got normal compartment syndrome. That wouldn't make any sense. So, know the triage list. When you're pre-testing a patient, there are several different tests you're going to do. You're going to do pupils. You're going to do the muscle H test. You're going to do confrontation fields, cover test, visual acuities. Which one of those is the most important one to take?
Visual acuity.
Visual acuities, very good. Ptosis, we already talked about. What is that? Droopy eyelid, very good. Ptosis is a droopy eyelid. Blood over the white of the eye. Subcount heme. How do you treat that? No. Reassurance. You'll get better. Keratoconus. What is that? No. You say dry eye? It's a cone-shaped eye, yeah. Cone-shaped cornea. How do you get keratoconus? Rubbing? Yeah, that's one way. Genetics also another way. Yeah, it's thin corneas. Do they know the exact etiology of keratoconus? No. No. Correct. How do we treat keratoconus?
Surgery.
What kind?
Shave it.
I don't know. Yeah. Corneal cross-linking.
No.
It's one where they put the riboflavin drops on UV light, makes the cornea really hard. Let's see. That's all I got. Any questions?
As far as pictures, information, so like how heavy is it going to be with pictures?
How many pictures are on the test?
Like how heavy?
How heavy with pictures? Gosh. Not super heavy. Ballpark, there's probably like 10, maybe 15.
Heavy.
The pictures are, I'm trying to get away from having pictures on the test because the Wi-Fi here sucks. And every single test I will have a student that has a picture that doesn't load. And then they'll reload the test and sometimes it still doesn't reload. Then I have to screw around up here pulling my picture up. So the pictures are typically there to help you support a diagnosis or treatment plan. Most of the information you'll be able to get from the vignette. And if you can't, I will figure something out and give you all of the opportunity to answer the question. But yeah, there's a few pictures on the test. All the pictures are from your slides. I don't get new pictures. And they're really just there to aid in your diagnosis. If you have any pictures issues next Friday, raise your hand and we will figure something out for you. What else? All right. Did you guys find that review useful or should I continue that? Yeah. Seems to be the good consensus.
We'll see you next Friday.
Yeah, we'll see. We will see. All right, I had a blast. I will see you all tomorrow. Thank you for being a good class. Adios.